Healthcare is not for sale. All that's for sale is medical treatment care, with the doctor at the top and this hierarchy of professionals underneath the doctor, the nurse, the dentist, the public health officer, and so forth. And what we've been working on for the last, this is the 35th anniversary. The PNHP was founded in 1988 as a result of the recently passed Medicare, Medicaid legislation that happened in the middle 60s. And it has been growing as a major resource for advocacy and research and education. The California Nurses Association and NNU is going to generate for the third or fourth time another single-payer bill in order to present to the general public and to see if the legislature will pass it. Whether they will or not is not clear, but what is clear is that the concept of a universal, rightful, public health grounded system that takes care of everybody and that has no cost at the point of service is something that has got to be embedded in the hearts and the souls of every single buddy in the population. And we have 1/3 of our population that cannot get services either because they don't have insurance or they can't afford the cost of ADA or the deductibles or the co-pays or the payments, the billing that comes afterwards. And what's happening to all of us that are caregivers in the system is that we're becoming literally squeezed into compliance in terms of time, in terms of quality of care, in terms of approval, in terms of oversight and administration, interdiction from non-clinical people in order to save money for the giant cartels, the pharmaceutical industry, the hospital industry, the insurance industry, and now the private equity community that's trying to buy out and own us, own all of us, and dictate how it is that we're going to care, how we're going to love, how we're going to identify and nurture the people that come to us suffering and lonely and scared and insecure and in trouble for our care. So I just wanted to welcome you to be together. We need to regain our footing and reestablish our member bonds between us because we should be family. At some level, our ground of transformation and success comes from the working class. Without the working class, we're sunk. In the diverse working class, the Philippine community, the Hispanic community, the African American community, the Asian community, the Native community, in order to rethink and own healthcare. Our system is owned by the corporate cartels, and the transformation is so radical that we have to change the ownership of what we do and who pays us and who we support in terms of our caring. Because if healthcare doesn't belong to the people, then it's not healthcare. It's something else. It's commodification, and it has become, as you can see, a barbarity in our society, and it's only getting gravely worse as other issues like the climate crisis are beginning to make people more terrified, the Republican-Democratic division that's going on, the Democratic working class division that's going on, are really stressing people out. And all of this attention at the problem of mental health is because the system has to somehow cool out the rage and the intimidation that people are experiencing, which is just terrible. What I'd like to do is I'd like to have each of you at least say who you are and how long you've been in PNHP and why it matters to you to be in PNHP, and specifically, what would make a difference in your life if PNHP would address that issue?
My name is Shivaram Bhatt. I practiced as a nephrologist for almost 40 years until 2011, of which 29 years in private practice in Merced. During my practice, I have gone through stages of payments for medical care in this country. initially it was private insurances or Medicare, Medi-Cal system here. And after this HMO systems and privatization of healthcare insurance companies, uh, Blue Cross became private, United Health, Aetna, and many other companies all went on Wall Street selling stocks, and their goal was making money, show profit after profit for the shareholders, and not their interest was not in patient care. And because of that, they started putting more burden on the physicians. I started feeling that as a practicing physician. I was, because I was in a small town, Merced, I was providing primary care as well as nephrology, primary care, internal medicine. So I had participated with the patient's pain in paying for their health care, and the big burden they had with the insurance company denying care and all this kind of thing. We tried to help them as much as possible, but we cannot push the insurance companies to do what is best for the patient. I felt all this. So when I retired in 2006, I joined PNHP, and I read all about PNHP. I went to their website, and also we had a colleague in Merced, Dr. Sandoval. He was very enthusiastic, and he was a member of PNHP. So he told us about what single payer is, and from there I joined PNHP as a member, donated a lot of money, and I'm so interested in, I get involved as much as I can, but because I'm retired, I don't have much contact with many physicians now, but my two sons are actively practicing, and they are also believers in single payer, and so that's my story. And
my name is Jim Barrett. I'm a retired family physician. Been retired about 7 years. I did my family practice residency in Merced, but after I finished my residency, I enlisted as an officer in the Indian Health Service so I could go work on the Hopi Indian Reservation in Arizona, which was very, in a sense, a life-changing event. I was very interested in Native American culture, but we had a hospital there, but there was no surgery. We delivered babies, but there was no surgical backup. We had to go 1 hour by ground ambulance to Tuba City, or hop on the ambulance plane and fly to Phoenix for an hour if there was any kind of emergency. So in a sense, it was really rural medicine. And that's sort of been my interest now is rural medicine, and in my opinion, how single payer may help that. So after completing the 2 years in Arizona, I was in Woodland for 20 years as a family doc, initially in an old-time private practice. The HMOs forced us to, in a sense, merge with the larger Woodland Healthcare Clinic, which then was bought out by Catholic Healthcare West. I didn't really like the corporate model of medicine, and I was invited to help start a clinic for the Clusa Indian tribe. So I took that job and worked there for 17 years. Again, Clusa was a relatively isolated county. They have a hospital. The two family docs at the hospital did the cesarean sections for OB, that sort of thing. There was no psychiatrist that was available. We became a federally qualified rural health clinic, but you're still trying to get patients the proper care. There was no physical therapy. You try to get someone to go to physical therapy, and they said, well, I don't have the gas money to go there. And so you end up giving them a pain pill. And I think now that you hear about hospitals closing and practitioners not wanting to go to rural areas, to me, I mean, if I was the boss, I would say that if we had single payer, we'd set up patient-centered medical homes which means that you have a computer system, you have a case manager, you have mental health, all wrapped into all under one roof, and have those at the appropriate places around. Because I purchased a farm, I joined the California Farm Bureau, so it's interesting to kind of see how farmers think. But one idea that I've had, and I haven't really had a chance to pursue it, is that, and I was never in 4-H or Future Farmers or anything like that, having grown up in suburbia, but if you had a plan that says you can do both, so if you have a 4-H student who's really, really sharp, you could encourage them to think about practicing medicine in the rural area. You could be the family practice doc in the rural area and have your farm on the side and enjoy both. You know, many learning institutions are in the big cities, and most graduates stay near where they did their residency. So if we could have more rural-based residency programs, which in a sense Merced was, there were only family practice physicians there, that might be one way to help get more physicians out into the rural area, if you pick the ones who really want to be in the rural area and associate with farming and that sort of thing in the first place. So, but again, that's sort of a whole challenge. Anyway, I can't remember when I joined PNHP. It was probably at least 10 years ago, but working for the Indian Health Service, that was a single-payer program. And in my opinion, it worked quite well, taking care of the Native Americans.
I'm Cal Hirsch. I recently retired professor of medicine. But my roots in medical practice after residency, I had 2 years in the National Health Service Corps. And like you, I served the poor and people without access to health care. But these are individuals who lived in the inner city, the north of Market area in downtown San Francisco. But they had essentially no access to health care. I worked in a clinic called North of Market Senior Services at that time. My office table was a recycled dental chair. Medications were expired or expiring medications donated by pharmacies, because otherwise they would have been thrown out. We made home visits to people who could not get access to health care because nobody else would. I then went on to sort of academic-oid career as an internist and geriatrician, but what I have always been concerned about is the fragmentation of healthcare in this country, the disparate payment for services, the limitations almost arbitrarily based on contracts and negotiations that health plans impose on who the providers are that patients can see. So a person may have been established with a primary care physician or a specialist, a nephrologist, and all of a sudden they're told they can't go there because they have a contract with somebody else. And so people are shunted back and forth. What is reimbursed varies, and this is awful. One thing that was encouraging during my 31 and a half years as a faculty physician was that we had and have a very active primary care program, both in internal medicine and in family practice. And a medical school that is enthusiastic about primary care. These are people who are ripe for being educated about what is wrong with the system. And I'll just close on a very different topic, which is data. You know, my career is data-driven. I mean, all of us are data-driven. But I made a career out of being a data-driven person, clinical epidemiologist. So I think one of the things that would really help sell physicians who are tired of dealing with the fragmented system, who have to go out in the real world and work for Mercy Health or some medical group, is to have data that we can draw on to basically fuel our arguments. You know, what you said, Bill, is inspiring and true, but it needs to be backed up by hard data. And that is difficult to come by. So that's one of the things I would like to see this organization do, if possible, as well as to continue, and I know that Dr. Bronston is working on this, proselytize among medical students and residents. Even residents who are in subspecialty care can be influenced, I think, to like the idea of a single payer. So I think that, that to me is the one small flashlight of light that I can see at the end of the tunnel. And we also have to educate the public better. Otherwise, legislatures don't stand a chance.
Thank you. My name is Adarsh Bhatt. I'm actually Shiv's son. I'm in practice now, so I've been in practice for about 20 years as a nephrologist. In private practice in the Roseville area with a Sutter affiliation. I'm wearing the shirt, but I'm not an employee. But I've been a member of PNHP for about 5 years now, and I've actually been quite inspired by everything I've heard so far and agree really well with many of the statements already made. From my perspective, my patients actually suffer from the fact that in the room, a silent player with myself, the provider, and the patient is the payer, just silently sitting there in the room, and actually the big obstructive force to most of my ability to provide care. There's a third party that's trying to extract money from the system for profit, and actually block my ability to actually deliver the type of care that I know my patients need. This results in a lot of problems. So one is the prior authorization process, which Medicare does not do. Medicare does retroactive reviews rather than blocking at the time of care being provided, so there's no delay in actual care delivery. Medicare as a payer is actually very prompt and very and electronically pays directly into your accounts, and then only retroactively then assesses what the quality of your practice but does do so, which is actually quite beneficial. So if we could globalize that rather than actually blocking at the time of, that a service is provided, and hitting the patient up front with the co-payments, hitting the patients up front with the fear that they're not going to be able to afford the care they need, we'd be far better off as a system. The fragmentation is also an issue that I've suffered. Patients would have their insurance plans switched at the end of a year, and all of a sudden they can't see me again. They're forced to break and establish with a new physician because their plan is contracted with somebody else. And these plans refuse to actually openly contract, and the negotiation process is extremely deliberately obscured. And in fact, there are huge disparities in a physician's pay based on contracts, which as a private practitioner, you have very little power to negotiate. These large health systems, unfortunately, also one of the cartels that Dr. Bronston had discussed, are able to then negotiate much higher rates from other payers than private practitioners like myself. So for exactly the same care that's provided by myself to a patient, somebody who's actually an employee of a different healthcare system could get a hugely disparate reimbursement for exactly the same care delivery. These are the types of problems that we're facing. That's also making private practice and rural practice much harder. So a private practicing doctor who might want to practice in the countryside would have a much harder time doing so because the contracted rates are so low. Whereas if he joined a healthcare system, the large system would not stick him in the rural area because it's not in a profitable venue for them. And so we're seeing, in my case, a lot of my patients then having trouble finding primary care physicians. I'm stuck as a specialist saying, yes, I can provide my specialty component, but boy, you really need a good primary care doctor to handle the rest, which I'm struggling. They're actually having a hard time with, specifically because of the payer system. And so if we simplified things, we would drop our costs, improve our quality, and take that silent third party out of the room, and the profit motivated goal out of healthcare.
Hi, my name is Joy Yoshioka. I am not a medical professional. I'm a really interested citizen and user of the health insurance programs in America. And I'm here because I see the disparities and the travesty of a for-profit healthcare system. And I've traveled, and I always ask people on the street what their healthcare system is, and everybody says, like in Europe and Japan, for example, oh, no problem. Why are you asking me this? It's low cost and I'm covered for everything. And so I'm thinking, again, that there needs to be serious reform in this country so that healthcare is a right and not a privilege.
I'm Sue Tapadisto. I'm a retired nurse, but I haven't done clinical nursing in a long time. Was supervisor for utilization management inpatients, so we did the prior authorizations for inpatient surgeries and stuff. And so I saw how surgeries like hip replacements that never ever were denied, we still spent administrative time reviewing them to do the authorizations, which is crazy. And I saw on the claims end of it, that a claim, to me now this is not a very political good thing for me to say, but since I'm not working there anymore, I can say it. So it seems to me that the claims reimbursement is all set to delay claims payment as long as possible. So they do that. I think they scan a claim and, oh, here's a problem, here the wrong social, it gets booted back to the physician or the provider, and then it gets resubmitted, it goes down, oh, there's another problem, and it goes back. So, you know, we need to really fix the system, and we need to be on par with other countries that have far better medical care than we have. We have people that, I remember when Obamacare was first being debated, NPR Radio did a series on, and they compared a gentleman in, I think, Rhode Island with somebody in London, England, with multiple sclerosis. And just the contrast, and I know this was years ago, but I think it's probably still the same. He wound up going bankrupt, losing his house, losing everything. And this woman in care that we think is so terrible as possible socialized medicine, she got the care she needed, she got reimbursed, and it was just the contrast is, anyway, that's my soapbox. So now where do we go from here?
I put together a team of 40 friends from around the country, past presidents of APHA, from the AMA and whatever, and we worked for a year, every Saturday for 2 hours on Zoom, every week for a year in order to craft the model that we call ourhealth.pub. One of the solutions is to globally budget all post-secondary public professional health education so that year for year would be exchanged to be assigned to rural and urban deserts, so that people, once they show up, don't have to necessarily be inclined to be in a rural community. They may just grow to like that rural community because they have to serve there, and after 2 or 3 or 4 years working in that environment, they build a family and a network. The issue of the cost issues, we don't really talk about savings, prosperity, and investment. The Congressional Budget Office has been looking at, a year ago, 5 major single-payer models, and they can't even begin to estimate the benefit, the savings that would come, and the prosperity that would come from freeing people from job lock. All of that is in the model, and what we're trying to do is to encourage our comrades and colleagues from around the movement to at least engage and look at the content of our health in order to discuss, as they craft their own models, how we're going to enrich, expand, but most importantly, create an inspiring campaign to move the general public. Because when this comes down to it, this is going to go to a proposition. So we have an enormous, enormous struggle ahead of us.